was all the way
Like
over
we
there.
have, hi, welcome. Looks like we have folks joining from all corners of the country, which I love to see. So keep that going. It's so good to see everyone. Welcome back to our first SDOH webinar of the year. My name is Natalie Graves. I'm the Director of Research and Implementation at Convergence Health. Quick note, you may have come to some of our webinars in this series where we were branded as Cynosure Health. We've now all moved over to Convergence Health as our new brand. Same great people, same great content, just a new name instead of colors and new logo. If you have questions about that, don't hesitate to shoot me a note. But we're so thrilled to have you all joining us today, as I mentioned, for this first webinar to kick off the SDOH screening series that's now in its third year. We've been thinking about and talking about this work for a long time. And I have some exciting updates to share with the group today about reporting requirements and also more conversation, of course, about how to actually get into the details of this work. So let's go ahead and jump in. As always, if you have questions, ideas, thoughts you want to share throughout today's presentation, please put them in the chat or raise your hand or chime in. There'll be opportunities to chime in and share. These sessions are meant to be interactive and as much sharing from you and the group as there is talking from me. Today's conversation will be a little more didactic than usual, however, so I'm going to start off with a refresher on the latest CMS reporting requirements. This year, the systems will open up for some of the first opportunities to optionally report some of the measures we've been talking about, so I'll give a couple quick updates there. Then I'll talk a little bit about, as the title suggests, how to use PDSA cycles or Plan, Do, Study, Act cycles in your screening program. We've collected an incredible amount of information and tips and strategies and stories from folks like yourselves all across the country on how to go about the different components of screening for and addressing social drivers of health. And so I wanted to just illustrate for the group how to keep thinking about testing and tinkering and learning as we're all implementing these programs. Then I'm thrilled to have Jessie Downs from the Alaska Department of Health with me today to share an inspiring and practical example of how she and teams in Alaska have done this work. I think you'll find it really informative. And she is a great example of all the different aspects of the work to consider when designing a program. And then at the end, as we have time, we'll have question and answer and the ability to share ideas or things that are working well for you with others on the line. So I asked everyone in the registration form two things. One, what is the biggest challenge or barrier you're facing? Kind of the most common question in QI. What are you struggling with? And then also, what advice do you have for anyone who's getting into this work? And I've got to say, reading that list of over 275 or some responses of advice that folks offered up to others in the ether, it just really made my day. I'm going to pull all that together and send it out as part of the meeting summary because there was practical suggestions in there based on experience. There was a lot of motivational ideas, and it really just boosted my spirits, and I know will boost yours as well. The number one piece of advice that folks had was to just get started or to jump right in. And I wanted to share a couple because there were some great aphorisms in there that they're just true. This work is complicated. It's difficult. There are a lot of barriers and challenges, but the number one thing you can do is just get started. Keep fighting the good fight. Rome wasn't built in a day. Just get started. It doesn't have to be perfect. And one that was said over and over again, start now, don't wait. The other piece of advice, a second and related theme, was to keep going. I don't know if any of you remember, Dory from Finding Nemo. This was the little fish that swam around and said, just keep swimming, just keep going. That was the other piece of advice that came up time and time again. So take it slow and steady. Never be afraid to be an agent of change. Keep spreading awareness of the SDOH initiatives, and it will catch on, and persevere. So these were two pieces of advice that, again, this is hard work. It's complex, it's challenging, there will be setbacks. And it was so encouraging to hear those two things. Jump right in head first and keep going. And those really are what PDSA cycles are all about and what we're going to talk about today. You can't design, set this up, brush your hands off and walk away from a project like this. It's something where we'll need to keep tweaking and tinkering. And PDSA cycles really are a way to do just that. Before we get into that, though, let me start with a couple kind of practical reminders or updates related specifically to the CMS requirements around SDOH screening and reporting. So there are 3 CMS health equity measures that have come out in final rules for IPPS hospitals over the last few years. The first measure is this hospital commitment to health equity measure. And this is a attestation. It's a structural measure of 5 different domains. This measure is actually required for hospitals, for hospital reporting beginning this year. So in April, when the IQR system opens up, hospitals will be required to go in and report on this measure. I'm not going to read the details here, but it's a really nice framework to understand what are you doing related to health equity, what are the areas you might need to focus more on, what are your areas where you've already built a lot of foundation that you can build on. And the SDOH screening and data collection is one component of this overall framework for health equity. So that's measure number 1, the hospital commitment to health equity. The next 2, and the ones that we focus a lot of our time talking about, are the SDOH or health-related social needs, whatever term you want to use, the screening measures around what health-related social needs your patients might have. And for these CMS measures, there are 5 domains that will be required for screening: food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. And there are 2 of these measures. The first one is your screening rate. So you'll be required to report the number of adult inpatients who were screened for all 5 of these measures. And the second is the screen positive rate, or the number of patients who report that, yes, they have a need in one of these areas. We could spend a whole hour talking about the intricacies of these measures, which we're not going to do today, but I've included this table in the slides, which we'll share after the event. And this has all of the links to the different data sources, reporting details, timeline information that you might find useful as you're thinking about what do I have to do by when, specifically related to reporting. If you have questions about this, put them in the chat. We can send follow-up information, or I'm sure others on the line can share their thoughts as well. If you are a critical access hospital, you may be thinking, that's nice, but perhaps that doesn't apply to me if it's only for those PPS hospitals. However, that would be incorrect. So critical access hospitals are also going to be required to submit these same measures through the MBQIP program, or the Medicare Beneficiary Quality Improvement Program, which if you are a critical access hospital, you're probably quite familiar with. So these same 3 measures that I just mentioned, the hospital commitment to health equity and the 2 SDOH screening measures, will be included in the new MBQIP measure set with reporting required in calendar year 2025. Now, I've heard that this detail is all a little bit kind of coming out in fits and starts. It's still all being finalized, and that there may be differences at a state level in terms of how the information will be reported and when. But all to say, this is not something that you can ignore. These requirements are coming for hospitals of all types, not to mention they're a great way to better understand the care that your patients need and improve those outcomes. The final update from a CMS reporting perspective is that last year, when CMS finalized their fiscal year 2024 PPS rule, they took this a little bit farther. And what they did is they started to put some teeth in the form of payment behind this screening and documentation of health-related social needs. So this is the language from the rule that describes the change. And what happened is that 3 of the ICD-10 diagnosis codes, specifically the ones related to homelessness. So if you're documenting a Z code that your patient is experiencing some form of homelessness, that code type changed from a non-complication or comorbidity to a complication or comorbidity code. So what does this mean? It's a lot of words. What it means is that CMS is starting to merge these 2 worlds of SDOH screening and reporting and payment. Because of the change in the type of code, this now means that there may be changes in reimbursement for patients who have those Z codes documented. So for years and years, we've talked about the importance of understanding what needs our patients might have so that we can deliver better care. We've talked about understanding what these needs are in our communities in aggregate so we can know how to devote resources or build new partnerships. And now it's important that we understand and document what these needs are of our patients so that we can get paid differently or perhaps more appropriately based on the level of care provided. So these worlds are starting to really merge together. And the more prepared you are to understand what those needs are, the more prepared you'll be as there are additional changes in reimbursement. All right, so that's the briefing on the latest from CMS and reporting requirements. Now I'm going to spend a couple minutes on this concept of alphabet soup or Plan, Do, Study, Act cycles for SDOH screening. Many of you on the call are probably familiar with the concept of Plan, Do, Study, Act cycles or small tests of change. And they are an excellent way to learn and implement and test, especially when you have a really big, thorny, complex challenge like setting up a screening process, and then setting up processes to actually do something about those screenings after the fact. There are so many different elements to think about, from which tool do I use to who's actually asking the questions to what do I do when somebody screens positive to how do I pull this data out of my EHR system. And this PDSA approach is a way to take it one step at a time, test something, see if it worked, and then test something again. So I also asked in the registration, what is your greatest challenge? And there were 3 themes that stood out here, none of them too surprising. The first was preparing and supporting your team members. This is something that we've talked a lot about, especially over the last 6 or 9 months, recognizing that it's difficult for patients who are responding to these questions who may have no context or idea why they're suddenly being asked these sensitive questions. And it's also really difficult for the team members who are now tasked with having these conversations. They might not feel like they have enough time, like they have an understanding of why they're asking these questions. They may feel like they can't do anything about the needs that people express. And so one of the best things you can do to make this experience positive for patients and to be able to truly help patients is to help your team first and help them understand why they're having these conversations, what resources are available, and educating, coaching, training, supporting them to do this difficult thing. The second greatest challenge was actually connecting people to resources. So what do you do when someone says, yes, I have a need? How do you set up referral systems? How do you identify resources in your community? What do you do when resources don't exist in your community? And then the third biggest challenge was actually using the data. So a lot of times we talk about how you can use the screening information you get in that individual interaction with a patient to say, you need help finding food? Sure, I can help connect you to a food pantry, or I can help give you these food bags we have available. But the idea of stepping back and looking in aggregate at all of this data we're collecting is challenging. Where do you pull it? How do you look at it? What questions do you ask? What do you do about it? So I thought I'd put together a few slides or ideas to test for a couple of these challenges. These are not solutions. They're not things that you can just pick off the screen as a checklist and say, yep, we did that, we did that, we did that, the problem is solved. But rather they're ideas of what others have shared with us has worked, or other things that people have tested that maybe haven't worked, but it was worth testing. So here are a few ideas on how to prepare and support your staff. The first is a big one, and that's to connect to the core and lead with the why of why you're doing this work. I had a conversation with a colleague a couple weeks ago who said she works in quality, so she knows why we're asking these questions, but she went to the doctor and the nurse she saw said, our so-and-so hospital is making us ask these questions and I don't know why, and it's kind of awkward, but we have to answer them. So imagine how that made the patient feel to hear someone say, I don't really know why I'm doing this, but I have to do it. And then imagine how that nurse felt. she probably didn't feel prepared to ask the questions. And so it ended up being not a great experience for anyone involved. So talk with your team about why you're asking these questions. What is your vision for how they can help improve care on a one-by-one basis and overall? And if people don't understand that or have questions about that, have conversations about it and help the team come to some agreement on why it matters to them. The second is to make sure you address those practical questions. If I can't remember where I'm supposed to pull these questions up, or when I'm supposed to ask them, or practically how I'm supposed to document, I'm not going to be able to have a conversation where I can really listen to the patient. So make sure all those little practicalities are figured out and tested with your team to make the workflow as streamlined as possible. And then the idea of starting small. You don't have to roll this out all at once. I've been hearing more and more that folks say, oh, we have these questions now in our EHR. They're really easy. We can just pull it up. The technology is available. But that doesn't mean that you can just roll it out all at once and all of a sudden have the whole team asking these questions. What you can do is say, hey, case manager Shelley, can you help me by testing out these questions with one patient? Then tell me how it went. Okay, that didn't work, try something else and build from there. So start small and then roll it out as you learn what works and what doesn't. So then that expanding is that systematic of going larger and larger as you learn more. But don't forget to study as you go along. So after you say, okay, all nurses or all case managers or whoever's doing your screening, this is now our standard practice. We do this every day. We have things rolled out. We have this going along. Don't forget to ask people how it's going, right? Just because the process exists doesn't mean it's working as well or as ideally as you think. So ask your team, how did that go today for you? What did you learn? Are there things that are not working so well that we could tweak or adjust? And give the team space in one-on-one conversations or in group conversations you might have to reflect on and adjust the process along the way. The final piece we hear a lot is, do folks use scripting? Scripting can be a helpful tool. It can give people some language to use if they're going into new conversations. And what I've heard from people who do this as part of their day-to-day job is, yes, scripting can help, but so does practice. The people I talk with who do this best or feel most comfortable or feel like they really can have authentic conversations with patients say, yeah, it's hard at the beginning, but when you do it over and over and over again, you develop your own way, your own authentic way of asking these questions. So scripting can help at the beginning, but really practicing is what gets you where you want to be. The second focus area or big question was, how do we connect patients to resources? And so I've been thinking about this because there are a lot of different ways that we might connect people to resources. And that depends on the resources we have within our facility and within our communities. So here's kind of a simplified ladder of sorts of different ways you might think about the way you offer patients resources. On the far left is to ask the questions, but do nothing. This is not ideal, right? We don't want to ask these difficult questions, have people tell us they need help, and then say we have nothing we can do about that, or worse, not even acknowledge that we asked. This might be a reality, though. You might not have resources in your community, or you might not yet know what resources exist. And so in this case, it's important to think that through. What will you do if somebody screens positive, but there's nothing you can do? How can you have a conversation and still make it beneficial to say, thanks for sharing that information. Unfortunately, there's nothing specific I can do right now, but let's brainstorm about how we might be able to work on this moving forward. The second step is what a lot of folks are doing, and that's developing some kind of a resource guide. So some kind of handout or even information in the medical record that gets automatically sent that says, you indicated you have trouble getting enough food. Here's some links to local food pantries or resources to different senior centers. And that can be a really nice way to collect all of the resources that are available in a community and hand it out for folks to access on their own. Now, you can probably imagine there are some limitations here. We don't know what patients do with that information. We don't know if they'll lose the sheet of paper or remember or feel comfortable reaching out and connecting with those resources. And so the next step would be to think about different ways that you might be able to actively refer or connect folks to resources. And that might vary based on what community organizations or services exist, and the pathways, either electronic or otherwise, that you might be able to set up. And then finally, looking over time, your screening data might show that you have opportunities to bring in new resources, new partnerships, new programs to your community or to your hospital. And so that would be a whole different level of investment of thinking about bringing new things to the area. So again, here are some ideas to test. Wherever you are, jump right in and try something on that list. There's something there for everyone. This is an excellent place to start engaging patients and families, because oftentimes they know what exists in the community. You can look online and Google what exists. That will give you a great starting list. And then the best thing you can do is to actually have conversations with people. Talk to the people who work at those organizations. What else do they know of that's not on your list? Talk to the patients who you're seeing every day and say, where do you go when you need help in this area? Is there something we can learn that we can then share with other people who are looking for help? Think about how you can integrate this idea of referral or follow-up into other practices or other processes that you might already have ironed out. So something like discharge phone calls. Can you say in a follow-up conversation, not only how are you feeling after this surgery, but hey, we saw that you needed help with utility bills. Were you able to call this phone number? Or could I give you this information again so that you could get linked up with that resource? And then also talk with partner organizations. So instead of only sending people out, get on the phone with those folks and tell them what you're doing. Let them know, hey, we're doing this new screening. We are getting a better understanding of what our patients need, and we're sending them your way. Can you tell us more about what you have to offer? Is there a better way that we can partner? How can we work to get patients connected to resources all throughout the area together? So that's going to take me to the end of my section, and I'm going to turn it over to Jessie now from the state of Alaska, who's going to tell us about her project with an FQHC and this wonderful organization called Connect Matsu. She's going to hit on so many of the things I previewed. So Jessica, I'm going to stop sharing and let you pull up and take it away.
Awesome. Well, thank you so much for the tee up. I was actually listening to your conversation thinking, yes and amen on so many of the things you brought up. So thank you. Also, I got a laugh at the use of alphabet soup. You're going to see lots of acronyms in this presentation too. So I hope I define them all, but if I didn't, please toss something into the questions. And if you have any questions at any point, feel more than free to pop off of mute and ask them. I don't mind interruptions, and sometimes waiting to the end, you're going to forget what you wanted to ask. So as Natalie mentioned, my name is Jessica Downs. I'm a nurse consultant with the state of Alaska. I work in the section of chronic disease prevention and health promotion. And I'm just going to chat with you guys about a pilot project that we did, really looking at using technology, integrating social determinant referrals, and kind of what are the outcomes, what do we see, and where are we headed next? And everybody's seeing the right screen, correct? Perfect. All right. So I like to start with a land acknowledgement. I live in a town called Eagle River, and I work in a town called Anchorage here in Alaska, both of which are situated on traditional Dena'ina Athabascan lands. And I am just thankful for the generations of stewardship of these traditional lands. And it is my hope that my work in public health really creates systems and opportunities for all people to thrive on these traditional lands. So as I mentioned, I work. Oh, I'm sorry.
Sorry to interrupt. We're still seeing the title page, actually.
Oh, biscuits. It is not working. Hold on. Let me stop sharing and try sharing again. Okay. See if it happens. Boop. All right. Are you seeing the introduction page or no?
Yes, but it never went away. So yeah. Okay, now it went away. So maybe try again.
I probably insulted Zoom once many years ago and it hasn't forgiven me. Okay. Do you see the intro page?
Almost. It says you're started sharing.
Oh yeah, I'm getting a spinning. So
Wanna try-
sorry, I got booted. Let me try one more time. I apologize, everybody. Technology. Okay, what
There
can
we
you?
go. We see the introduction.
All right, if it doesn't advance, we'll abandon ship and I'll just have you pull it up, Natalie, and walk
Okay.
through. Okay.
Sounds good.
All right, so as mentioned, I work for the Department of Health in the section of chronic disease prevention. I'm in a unit called Health Systems Collaboration, which is really made up of 4 clinical conditions: dementia, cancer, diabetes, and heart disease. And those conditions were kind of lumped together because they require the health system to really move the dial on the public health interventions. So my unit's full specialty is that we work with health systems across the state to figure out ways to integrate public health practices into clinical medicine. Oh, there we go. All right. Okay. So I'm going to start with the story of Frank. Frank is obviously not his real name, but his story is real. Frank's an elder. He lives in Alaska. He's on the road system. He's in an area of the state that we call the Upper Sioux or the Upper Valley, about 3.5, 4 hours outside of Anchorage. But it's very small community. It's outside of all of our big urban hubs. He's in a really small town. He's had a big change in his health recently and he needs a wheelchair, but he was discharged without one because he couldn't get his DME through his insurance. It was being very slow. He's having a really hard time. There's no DME distributors in Frank's really tiny town. And he's just been struggling. There's a big out-of-pocket cost if he wants to buy one. He's really struggling. So his neighbor actually had a child, and I mean, the sad story is that this child has passed away, but when the child passed away, he left behind a child-sized wheelchair. And so that neighbor gave Frank his wheelchair. So Frank is an adult man, a large guy scrolling around his house in a little child-sized wheelchair because it's the best he can do. He doesn't leave his house. His wife, who's his primary care provider, is the only person who's out trying to get groceries. She doesn't drive really well. All the problems, you guys have seen lots of patients like this. He has an appointment with his primary care provider to follow up on something else not related to his wheelchair. But before he comes in, he sent an email to complete a form. It's called the Prepare form. And the Prepare form asks some questions about things like, are you able to access food, transportation? Are you having a hard time with food security? He fills out the form, goes to his appointment, and the next thing he knows, without any additional work on Frank's end, he gets a phone call from an organization called Connect Matt Sue. They hear his concerns, they make a few different calls, and bada bing, bada boom, just like that, Frank gets connected with a charity in his community that has an adult-sized wheelchair and gives it to him to use for as long as he needs it. The moral of Frank's story is that this story is common, and it's not because his care team isn't practicing at their highest level. It's not because Frank is struggling to navigate the healthcare system. It's because there's no single entity within our, communities, within our healthcare system that can navigate all of these needs alone. Nobody can do it by themselves. So we had actually implemented this e-referral system at Frank's primary care provider just a couple of weeks before his appointment to follow up with his provider. And with no additional work from any single person, we were able to link multiple technology systems together to wrap our services around Frank without any additional burden on any member of his care team. So this is just a really quick level setting slide. You guys know this. Social determinants of health are the factors associated to where you live, are born, where you worship, where you play, that impact your ability to access health and decreases your health outcomes. I love this quote from HP 2023, excuse me, which basically just says, telling people to change their choices isn't going to address these health disparities. We need to do more. We need to connect our systems together so that we're able to reach these people's environments, and that will really improve their health. So a really quick snapshot of the project. We located it in a federally qualified health center. It's called Sunshine Community Health Center. They have 2 clinics and 7 school-based health centers, and they're located in that same part of Alaska called the Upper Valley. The participants included us here at the state and the Department of Health, Sunshine, an organization called Connect Matsu, and an external vendor called Telask Technologies. And we kicked off the project. It took us about a year of planning, finding the partners, building the bridges, all that business, but we kicked off on 5/1 of 2023. Connect Matsu is a comprehensive referral hub. They have hundreds of local, state, and federal resources, all kind of connected through this central agency. And we also decided if we're going to build this project, let's also connect in the Alaska Tobacco Quit Line, which offers comprehensive tobacco cessation services. And we were able to fund this project in the pilot phase through the Department of Health as a COVID pilot under our COVID dollars. And in doing the project, we were able to connect the Athena EMR. Salesforce is the platform that Connect Matsu uses. Telask has a Quit Manager, and then the Alaska Tobacco Quit Line system. This is just a really high-level snapshot of what the project looks like. I'll dive into these bubbles a little bit more. I know it's kind of hard to read the tiny writing in them, but you can see the goal was for the state to support the interconnection of all these agencies together. This is a really kind of high-level overview of what the project looks like. We wanted to screen patients, connect them to customized services, and then communicate back to the organization what the outcomes were of those connections. Start tracking the outcomes. Are we seeing improvements? And then using this data that we're gathering to identify service gaps and regionally specific care needs within that community so that we can start finding community-based organizations to address those needs. So Sunshine Community Health Center has the patients complete the prepare form when they are new and then once annually thereafter. And they actually send the prepare form to the patients using a vendor called Epion that connects to their EMR, sends it out either via email or a secure text messaging. Patients fill it out, the data is ingested back into their EMR. If the patient hasn't completed it before their appointment, they sit down with their care management team and complete it in the waiting room while they're waiting to go back. Currently, the process is using an opt-out model where patients fill out the screening form and then they have to select to have their data shared with the SDOH service. But we are this month actually moving to an opt-out model where everybody who has a social need is going to be referred over and they have to elect not to receive the service. So we're making a change just because we identified a gap in our PDSA cycle and wanted to catch more patients. During the intake process, all patients are screened for tobacco use, as is, I'm sure, standard, including vaping and smokeless tobacco. And every patient who identifies as positive for tobacco use is sent over to the Telask Quit Manager system, which I'll navigate through with you guys in just a minute. So we're using opt-out for tobacco and opt-in for social needs in the first phase of this project. Sunshine Community Health Center navigators will sit down with the patient if they have any questions. They weren't sure about their form. They say, I filled it out, but I've changed my mind. I now want my needs addressed, what have you, to try to help patients understand if they have any questions about the SDOH screening form. Once the patient data is in the medical record, it's then transferred over to Connect Matsu using a secure SFTP transfer. The data is sent over daily, and currently our vendor Telask is providing that SFTP, but I'll talk in a little bit. We're transferring ownership of the SFTP over to the Health Information Exchange for data transfer, but it's just a secure connection. The data is not manipulated in any way. It's sent over to the vendor, to the Connect Matsu, who's able to then reach out to the patients. So they ingest the data into their Salesforce system, and they're connected with specialists who then reach out to the patient and see if they can address their needs. The really neat thing is that it gives Connect Matsu the opportunity to say, I see you've identified that maybe you don't have access to firewood, but while we have you on the phone, is there something else we can help you with too? So they're able to really address the needs, not just that are identified, but any additional ones the patient might have also. And then they collect and gather the outcomes data, which they send back to Sunshine. Sunshine's able to ingest it, put it into their patient chart. So the next time the patient is seen, they can address this social need. Hey, it looks like you were having trouble with transportation. I see we made this connection. How's that working? And if additional resources or needs are met, then they can initiate data back to Connect Matsu to readdress the social needs if necessary. One very cool thing about this project is that Connect Matsu is also able to gather all this needs data, start looking for trends, identifying service gaps, and they have themselves some funds that then they can reach out to the community and say, our data shows that this particular need exists in this community. Could your organization address it? We can fund it. And so really they're able to start using this data at the next level. The Quit Manager exists within the vendor TellAsk. Basically, it's a tool to assess patients' readiness to quit. Once they're ready to quit, they're immediately transferred over to the Alaska Tobacco Quit Line, who then takes over the cessation process. But patients who are not ready to quit are then entered into a tracker and contacted back on a regular basis until they are ready to quit and make a quit attempt, or at a point where they opt out and then they're removed from the system. It's great. It takes over all of the case management tracking for tobacco use, which can be a heavy burden from some organizations and frequently gets dropped just because of the volume of the work. And the Quit Manager is completely invisible. It's fully embedded into Sunshine. They call from a Sunshine number, and they actually have a voice of a Sunshine community member on their voice messaging system. So it's somebody from the community reaching out to other members of the community. This is just a really high overview of what the Quit Manager looks like. They call, confirm the identity, confirm the tobacco use, and then assess for readiness to quit and make the connection to the quit line when they're ready. So how did our project do? May through December, we had 320 total patients who screened positive for social needs and were referred to have those social needs addressed. And here's just a really high level split out of what those SDOHs that were identified. In that same period of time, 521 Alaskans are currently in the Quit Manager system. So they either have not identified readiness to quit or they haven't fully navigated the system yet, with 61 referrals to the Alaska Tobacco Quit Line. I talked to my evaluator about this and said, if Sunshine made 0 referrals to the quit line last year and 61 this year, does that mean I get a claim a 610% increase? But apparently not. I guess data doesn't work that way. So still, nonetheless, this went from a 0 referral over the many years of Sunshine's history to 61 referrals in just a year, which is great. So where are we at in process? Kind of circles back to the PDSA cycle again. We've completed the development and the implementation of our project at one site, and now we're really looking at what does widespread adoption look like? Are there plans that we can integrate additional care facilities into this referral system, and or can we replicate this system with other facilities across the state? And if so, how do we fund it? How do we sustain the adoption of it outside of this grant funding? As I mentioned, the project was funded through COVID equity dollars, but we're really working on scaling it outside of the grant and figuring out ways to do it. One of the ways that we're working on it is that we are transferring the SFTP file transfer over to the Health Information Exchange. We have one state HIE that partners with the state on some projects that we work on, including this one. And they are linking, this is the first time ever that we've been able to link a community-based organization to the HIE using this SFTP. So patient data will be collected at Sunshine, but then sent to Connect Matsu to then work on an address. Sites that don't have places like Connect Matsu, if you don't have a social needs hub in your community, we are working on another project where we're trying to create links using the HIE and some social needs dashboards, but then are accessible to social workers and community health workers who are able to identify and address the social needs in their community. Really big picture is figuring out how to balance multiple technologies and projects to link them all together so that in the end, what we're creating is services that wrap around the patient without adding additional burden to staff or taking away from staff's direct care time. And that is my presentation. Are there any questions I can answer for anybody?
Thanks so much, Jessie. One question in the chat to get us started from Alicia. What type of employee is considered a navigator?
Sure. Yeah, that is, let me stop share so I can see your lovely faces again. That's actually a continued project that we're having at the state as well, a little bit outside of this project, overlapping a bit, is that we need to do some title control and some standardization around things like what is a community health worker. licensure, some standardization, so that then we can seek out reimbursement for community health workers. So right now, the title is really just your organization decides who's going to do the patient navigation. At Sunshine, they're generally community members who are not CMAs or CNAs, but rather their whole job is to work with the patient to sort of navigate the healthcare system. And we do have some training that we offer through our comprehensive cancer program for health system navigation to sort of help that level of staff member. What we're working on in the future, and I know a lot of states are way ahead of us on this project, but is standardizing what is a CHW, putting some competencies around it, and then standardizing the work and scope for that particular job class.
Thank you. Anyone else have questions? Okay, just raise your hand or put it in the chat. I see Katrina, thank you for, I'm going to read this because I saw a milkshake. All right. So, or Katrina, do you want to come off and share this, or I can share it out with the group?
So we have a new community health improvement specialist at our organization, and she has developed this community resource, and we are in the process of, the baby steps literally of applying this to our organization. So through the screening process for the social determinants of health, if a patient were to screen positive and the nurse, the provider, whomever were to identify that, they could then generate a referral to this, what we're going to call the spilled milkshake. The spilled milkshake is just a collection of resources available in our community that she can then take those patients that are positive, screen them for their needs and interact with them a little bit more, and then connect them with the community resources. And it sounds like it's pretty similar to the Alaska project. And she actually, I think that there's been this generalized belief when she first started that the spilled milkshake was just for behavioral support for caregivers. But in reality, it's just a referral title for us to be able to connect our patients in the community with resources. And it is such a great idea, and it's so in alignment with this project that I think it's going to be very helpful for us to be able to move forward with this and connect the dots.
Thank you.
I'm dying to know where the name came from.
Yeah, yeah, I was going to ask that too. Where did spilled milkshake come from?
She heard it from another community health improvement specialist on a listserv down south, and that's what their community named theirs, was spilled milkshake. And so that's what her goal was, to just create something similar to that.
Thanks for sharing. All right, a question from Liliana. What are the validated screening tools you recommend using that are in alignment with CMS requirements beside the AHC tool? Jess, do you want to, I think you mentioned Prepare. Do you want to talk a little bit about that?
Yeah, Prepare is the form that the Sunshine Community Health Center actually wanted to use, and I love the reason they chose it. It is a validated form and it's great, but they chose it because it was already available within their EMR's portal, or the Orchard or whatever it's called that their EMR has, that lets them pick certain fields. That Prepare was already uploaded into it. So we chose that form. As we're heading sort of into this next level of the project, they've actually pulled back from using the Prepare form, and they've put in some cultural and regional specific modifications into the form itself. So they've kept the basics, but then they've added some customization to it so that they can start doing in-house triaging and identify if this is a need that their in-house community health worker can address. They want to refer it there. If it's a more complex need, they want to refer it to Connect Matsu.
Great. Liliana, go for it.
Thank you. Thank you so much, Jessica. It is my understanding that the Prepare questionnaire uses the question about that in the last 12 months, do you blah, 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 right? So do you add additional questions to specify the need at the present time of the appointment or the visit or whatever?
Depending on the question, their current customization, they really wanted to add more specificity around things that they felt that they could address just in time. So they share a backyard with the food bank, for example. So in that question, if the patient answers yes for having had history of food insecurity, then they ask further details. Do you currently need food? Are you aware of our food bank? Do you have a relationship with them? So they chose to tier the things they felt they could meet just in time so that the patient walks out of their appointment with their needs met while they're there.
Thank you. And is there any chance that you can share your final form with us? With those
Let me
additional
check
questions?
Yeah, I'll check with Sunshine and see if they're okay with sharing it. It's still in development, so it'll
Sure.
be a couple of months probably until they kind of come to a settled on what it looks like, but absolutely.
Thank you.
I think, Natalie, we had a presentation from another tribal organization that put some cultural tailoring in their prepare form too. I don't know if that's something they would mind sharing.
Yeah, that's a great point. I can't remember the details, but I can follow up on that too. You're exactly right. There was another tribal organization in Alaska who talked about how they added some questions, modified some questions to make it more relevant to the community. Yes, thank you. North Sound Health Corporation in Nome. Thank you so much.
Deanna beat me, yeah.
Other questions for Jessica, for me, for anyone else on the line? So my question, Jessica, is what can people do if they don't have a grant? Or where could they go look? Who could they talk to in their state or in their health department who might be interested or might be already doing this kind of work that they could get linked up with if they were interested in kind of tapping into this network?
I would say contact your state's behavioral health programs, only because many and most of the behavioral health programs across the US are funded to do what they call community coalitions, focusing on addressing SDOH needs for the behavioral health population. But these coalitions are generally gatherings of people who address social needs. And if there's like a formal coalition already existing, a wellness council, something like that, that might be a single referral site that even if you didn't use technology, even if it was something like printing a list every week and handing it over to that council to then address these social needs, there's probably likely somebody doing the work of social needs in your community already, just figuring out who they are and connecting with them.
Great. All right, well, keep the questions coming. I have just a few things to close us out. But drop questions in the chat or raise your hand. I wanted to just close us out with a reminder of the network and resources that the Convergence team has created. So if you haven't checked out the online community yet, that's an area where you can share questions, add resources. You can access all of the recordings and PowerPoints from the events that we've had over the last 18 months or so. And there's also tools and resources, examples of how to pull together a resource list for a community, for example, that are posted on that site. All you have to do is create a free account and then you can log right in. On that site, we also have created 2 mini courses about some of the most common challenges that have come up in these conversations. The first one is about how to select a screening tool. And I think this one is in a lot of ways is already out of date. When we created this, there was a lot of talk about which tool do I use, which is, the best way to think about this. And now I hear most often, oh, we have something in our EHR that's just come online. And so in a good way, this could be out of date if you already have something selected. But the second mini course is about this challenging question, but probably most important question of how do you ask these questions in a way that creates a trusting environment for the patient so that they feel able and comfortable in sharing their kind of full situation so that you can best understand what they need and how you might be able to help. And we have some great tips in there, all based on what we've heard from others who are doing the work and an interview with someone at a small hospital or a hospital in a rural community in Colorado. And then for those of you out there who are sweating the data collection and reporting, we put together a data collection tool that outlines all of the components of the measures that will be submitted to CMS. It has all of the links to the specifications and all those exclusions and all that detail. So hopefully it's a helpful tool to figure out what exactly do I have to collect. Pull that information together in one spot so you'll be prepared to submit when the time comes. And we'll be continuing to have more events like this over the coming year. We're partnering with PFCC Partners, our favorite group on patient and family engagement, who many of you know, to put together a session on what does it actually look like to partner with patients and families in this work. We talk a lot about how we should and could do that. And so our next session is to really walk the talk and do that kind of co-design session with patient and family partners to show how you can actually implement that. And then to close out, yes, Rhonda, I will put the link to the data collection tool in the chat in just a second. But just to close us out, a lot of times we hear, and I think this is a very natural reaction, what if I can't help? I'm not going to be able to solve everything. I might not be able to solve anything in this conversation that I have, often challenging conversations with patients. So what if there's nothing I can do? And what we hear from patients when we ask that question is the fact that you ask and listen and show up makes a difference. You know, think about a time when you were struggling and you called someone on the phone and they just picked up the phone and listened. That makes a huge difference. And so in a lot of ways, this work is about picking up the phone and listening and being there. And the more that we have these conversations and understand what's going on in our communities, the more we can think about how to change and make things better. So just keep going, jump off, keep swimming, and continue to share what's working with us and with your peers across the country. And we appreciate everything you're doing and hope to see you on the next call. And I'm going to grab that link in just a minute. Thanks so much, everyone.